So now you're performing the valgus stress test. So this can be done if you're suspecting one plane medial instability. So this stress test is going to also be done at 0 degrees of extension and 30 degrees of flexion, but this time you are not going to be using the table as you would in the Houston's valgus test. So with this one, you are just going to place your hands. One hand is going to go on the outer aspect of the patient's knee, and then the other hand you are going to place medially at the ankle, and you are just going to be kind of pushing out laterally. That would be with my right hand, so I'm applying a valgus stress at the knee. This is going to be 0 degrees of extension, so valgus stress is being applied here. And then you can also perform the test in 30 degrees of flexion to help isolate medial compartment ligaments. So the hand placement is same, and you're just applying a valgus stress with the knee in 30 degrees of flexion.
Positive tests would be reproduction of patient's pain or laxity.
Now we are performing the Veris stress test, which is for one plane lateral instability. Again, this test can also be performed at 0 degrees of extension and 30 degrees of flexion, but unlike the Houston Veris test, you will not use the table to support the proximal thigh. So what you're going to do is this: you're going to grab the lateral aspect of the ankle and put your hand on the medial aspect of the knee, and this will allow you to get a varus stress to occur. So this is being performed in 0 degrees of extension, and you are placing a varus stress, whereas you can also do this in 30 degrees of knee flexion, and if you repeat in 30 degrees, this will help to further isolate lateral compartment ligaments. Again, hand placement is the same, and apply that varus stress.
And again, a positive test would be as you do this, you get a reproduction of the patient's pain or you feel laxity or excessive motion.
So similar to the varus and valgus stress test, there's the Houston valgus and varus stress test, which are very similar, but for these tests you're just going to be using the table to stabilize more of the femur, and then you're still going to apply those varus and valgus stresses. So you're going to come around and you're going to place one hand to move the leg kind of off the table, just so now the femur is stabilized. You want to make sure your outer hand is going to go along the knee, and then in your other hand you're going to place it medially around the big toe or first ray. So with your hand placement here, you're just going to apply a valgus stress that is happening at the knee. So again, make sure that hand is on the medial toe, so like the big ray, and then outside applying that valgus stress. That was at 0 degrees of extension, and you can also perform this in 30 degrees of flexion. So again, just kind of flex the knee to 30 degrees off the table, and hand placement is the same, and apply that valgus stress.
And a positive test would be reproduction of patient's pain or laxity.
Similarly to the Houston valgus stress, there is a Houston varus stress. So it's the same concept. Your patient's going to be lying in supine, and you're still going to use the table to kind of stabilize the patient's femur. So what you're going to do is you are going to move the leg off the table in order for this to be a Houston's varus test. And now we are going to move the leg off the table. And this time, instead of placing your hand by the big toe or first ray, you're going to place your hand by the 4th and 5th metatarsal. So place your hand on the outer part of the patient's leg, about 4th and 5th metatarsal, and then you're still going to place your hand onto the outside of the knee. And now as you apply your pressure, you're going to be performing a varus stress. So again, this is at 0 degrees of extension, performing a varus stress by having your hand placement on the 4th and 5th metatarsal and outer part of the knee. You do this in 0 degrees of extension, and you can also do the Houston varus stress at 30 degrees of flexion. So the same thing will occur, your hand placement will be the same. You're now just going to place the leg into 30 degrees of flexion. So leg off the table, give it a slight bend so you're in 30 degrees of flexion, and again, apply that varus force.
And a positive test would be reproduction of patient's pain when performing this test or laxity or excessive motion.
So now we are performing the anterior drawer test, which is a test if there is suspected anterior instability. So for this test, you're going to have your patient lying in supine, and basically this test can help us to determine if there is an ACL tear. So you're going to flex the knee to about 90, and you just want to then tell the patient you're going to sit on their foot to stabilize. So in this position, you're then going to take your hands and you're going to wrap it around the back of the knee. And then what you want to do is as you place your hands in this position, kind of wrap around, get a good hold, and you just want to kind of grab the tibia and pull it forward. And as you pull forward, you're just kind of feeling if there's any sort of excessive or limited motion. So you just want to make sure in this position you're grabbing a hold of the tibia and you're kind of pulling towards you, so you're doing more of an anterior pull of the tibia. So a positive sign for this test would be that as you apply that anterior pull, if you get excessive motion or a clunk, which would indicate that there is anterior instability and possibly a tear of the ACL. So another test to determine if there is anterior instability is the Lachman's test, and this is actually the gold standard for if you suspect an ACL tear. So what you're going to do is it is similar to the anterior drawer test, except you have a little bit less knee flexion. So you're just going to place your knee kind of under the patient's knee, so you're getting a little bit of flexion, but you're also helping to stabilize that. So again, you're going to then place one hand on the distal femur, and then the other hand is going to be with applying that anterior drawer. So place your leg under the patient so you're able to get a little bit of knee flexion. The top hand is going to come and stabilize the distal femur, and then I'm going to use my other hand to apply the force to pull kind of anteriorly. So I'm grabbing a hold of the tibia and just pulling anteriorly. A positive sign would be that as I do this, I feel a mushy or soft end feel when the tibia is moved forward. So there are several tests we can do if you suspect a posterior instability. So the first one we are going to be doing is the Godfrey test. So to perform this test, your patient is going to be lying in supine, and you're going to flex the hip and knee to 90. And as you do this, you're just going to be looking at the patella and the tibia. So mainly you're going to look at the tibia, and you want to see if there is a drop-off in relation of the tibia to the patella. So you will be looking here for a sag or sulcus of the tibia in relation to the patella, and if you do see that drop of the tibia indicating a sag or sulcus, that would be a positive test for posterior instability. So that was the Godfrey test. Now another test for posterior instability would be the posterior sag sign test. So with this test, it is going to be similar, except the patient is still going to be lying in supine, but now you're just going to have the knee into about 80 to 90 degrees of flexion, and you are still going to have the foot now resting onto the table. So as the patient is in this position, a positive sign would be if you see the tibia kind of sag or drop off from the femur in this position. So this would be a positive test for posterior instability for both of these tests if you see a sag or sulcus of the tibia. So now we are performing the posterior drawer test, which is similar position-wise to the anterior drawer test, except this time you will be pushing the tibia more posteriorly. So the patient is going to be lying in supine. You're going to flex their knee to about 90, and then you're going to inform the patient that you're just going to be sitting on their foot to provide some stability or support. You're going to wrap your hands around the back of the patient's leg, just like this. And then you're just going to use your hands now, and you are just going to apply a posterior force on the proximal tibia. And as you apply this posterior force or pressure, a positive sign would be if you get excessive motion or you get a clunk. So if you get limited motion or it doesn't really move, then that could indicate a negative sign. And this posterior drawer test is testing for posterior instability and is a good test if you're suspecting a PCL tear. So a positive sign would be excessive motion during this test or a clunk. So this test is good to be performed if you're suspecting that there is multiplane instability. So you can combine some motions with your drawer test in order to see if this test is positive. So what you're going to do is place the patient in that anterior drawer position, but now what you're going to do is you want to start by internally rotating to about 30 degrees. So you're doing internal rotation of the tibia, and then you're still going to do the same thing. You're going to wrap your hands around the back of the patient's leg, applying that anterior kind of pulling towards you motion. And if this is painful or if there's laxity while you're in this internal rotation, that could indicate there is more problems with the lateral structures. You can also do this test by turning the patient's foot into external rotation. So now you have externally rotated the tibia. You do that about 15 degrees. Same thing, you're going to apply an anterior pull, so you're going to pull towards you, and a positive test would be if there is laxity in this position or it reproduces the patient's complaints of pain.
Okay, so now we are performing the pivot shift test. So we can do this in two ways. So the first way, we're going to be doing it as more of a reduction test. So you're going to start with the patient in extension, and you're going to internally rotate the tibia. And while you internally rotate the tibia, move the patient into 90 degrees of hip and knee flexion. So this is more of a reduction test, starting in extension, then internal rotation, moving into flexion. A positive test would be as you do this movement, you have a clunker reproduction of the patient's pain. You can also do this test for more of a subluxation test. So with this, you would start in flexion, internal rotation of the tibia, and then you would move into extension. So start with the knee in flexion and internal rotation of tibia, move into extension, and again, a positive test would be a clunker reproduction of pain. Okay, so now we are performing the reverse pivot shift test. So very similar to the pivot shift test, the only difference is now you're going to bias for posterior lateral instability by doing external rotation. So you're still going to apply a valgus force with the knee, so still moving from flexion to hyperextension. The only difference is you're now going to externally rotate as you move into extension. Positive test would be if you get a clunker reproduction of the person's pain, and this one you're biasing more for posterior lateral instability.
So now we're going to be performing the Thessaly's test, and this test is typically good to do if you are suspecting some meniscal involvement. This test can be done either in full knee extension or 20 degrees of knee flexion. The clinometrics are better in 20 degrees of knee flexion, so that is what we are going to be performing. It'll also be good to instruct the patient that they have, let's say, headlights on their hips, so making sure that they follow their hips and keep their hips in line with you. So you're going to ask the patient to stand on one leg, and then you're going to have them bend to about 20 degrees knee flexion. They're going to place their hands in yours, and you're just going to instruct them to follow with their hips, so follow you. So basically when they do this motion, they're getting some twisting on that menisci. And then same thing, you're just going to have the patient follow with their hips to the other side. And a positive test would be that as you do this, you get a clicking, popping, or you get the reproduction of the patient's pain. And that would be a positive test for Thessaly's, which could indicate meniscal involvement. So another test you could perform if you suspect a meniscal lesion would be McMurray's test. And this test you can actually bias into either external rotation or internal rotation. So if you suspect a medial meniscal problem, you would do external rotation, and a lateral meniscal would be internal rotation. So if we were testing for the medial meniscus, you're going to put the hip and the knee into 90 degrees of flexion, and you're going to use one hand to palpate and find the joint line, and you want to keep your hand on that medial joint line because you're going to be trying to feel for a pop or click. And then what you want to do is using your other hand, you want to keep the leg in external rotation, so externally rotate out, Keeping that external rotation, you then want to straighten the knee. So fingers on the joint line to feel for that pop or click while externally rotating. And if you feel pop or click or get a reproduction of the patient's pain while doing the external rotation, that would indicate a positive test for a medial meniscal involvement. If you want to test for the lateral meniscus, same thing, hip and knee in 90 degrees of flexion. This time you're going to internally rotate. So place the hand again on the joint line. This time you're just feeling for the lateral joint line so you can feel that pop or clip, and internally rotate. Now with that internal rotation, keeping that, move the knee into extension and straighten. And again, a positive test for a lateral meniscal involvement would be while you hold the patient in external rotation and straighten. If you feel that pop or click or reproduction of pain, that would be a positive McMurray's test. So another test you could do if you're suspecting meniscal involvement or meniscal lesion is the Apley's test. And this you can do two different ways, either compression or distraction. So for the compression part, you're going to have the patient lying in prone. And this is typically if you're suspecting meniscal involvement. And you're just going to flex the knee to 90 degrees, and you're going to kind of place your hand on the patient's foot like this, and you're just going to apply pressure and then move into internal and external rotation while applying that compression. So apply your compression straight down, and then you're kind of, as you move, you're grinding down onto the meniscus. And then a positive test would be is as you do this, you reproduce the patient's pain or complaints. You can also perform Apley's distraction, where if this is painful, it typically more indicates a ligamentous problem. So what you're going to want to do is you are going to place your thigh and kind of hold the patient down, and you're just going to kind of pull up, applying that distraction force. And again, a positive test would be if you reproduce the patient's pain or complaints. And distraction would be more of a ligamentous problem if that is painful. So the last test we can perform if there's a suspected meniscal lesion is the Egge's test. So similar to the McMurray's test, you're going to do internal and external rotation. So to test the medial meniscus, you're going to have the patient stand apart, and you're going to maximally externally rotate. And as you're in external rotation, you're just going to have the patient perform a squat. And as they do this in external rotation, if they reproduces their complaints or reproduces their pain at the joint line, that could indicate a positive test for medial meniscal involvement. You can also do this test for the lateral meniscus, so same thing, you're just now going to have the patient internally rotate. Now during that internal rotation, have them perform their squat, and same thing, if it reproduces the patient's pain at the joint line, that would indicate a positive test for lateral involvement since you were in internal rotation. So now we are going to be performing the brush or stroke test, and this is a good test to do if you're suspecting that there is effusion at the knee, and it's also good because it can even pick up if there is minimal effusion there. So what you're going to do is you're just going to be using a brush or stroke technique. So let's say the person had some effusion, so more on the medial aspect you're going to stroke superiorly, so you're stroking upward, and you can do this a couple of times. And then what you would do is you would come on the opposite side, so the more lateral side, and you would want to stroke downwards. So what you may see is that as you stroke downward on the lateral side, you may see a little bubble of effusion kind of pop up, and that could indicate that there's some effusion in more of the inferior medial aspect of the capsule. So you can also grade this. So as you stroke, if you go up and then stroke down, you see a small bubble. That could be a 1+. A 2+ could be if you see more of a bigger bubble of effusion when you stroke up and down. If when I push up and I don't even have to come back around, that would be a 3+. And a 4+ would be if there's so much effusion you can't even push it out of the medial aspect of the knee.
So now we are performing the patellar tap test. So what you're going to do is you want to stabilize the patella, and you're basically just then going to stabilize from the superior and inferior aspects, and you're just going to come and tap on the patella. A normal knee, it will typically, when you tap, it will move down into the femoral condyle, but if there's swelling, then the patella is more so going to feel like it's floating there, so you won't feel like you get contact when you tap. So again, a positive test is if you feel like the patella is more so floating, and it is not getting contact with the femoral condyle, which would be a positive test.
So now you can perform the patellar grind test, which is going to be done if you're suspecting that there is patellar femoral alignment issues. So what you're going to do is apply some compression onto the patella, so you are pushing the patella into that patellofemoral space. So as you compress down the patella, you then want to just ask the patient to tighten the front of their thigh. And a positive test would be as they do this if you see excessive crepitus or also a reproduction of the patient's pain or complaints as they tighten the front of their thigh. You can also perform this test with the patient seated. So what you're going to do is you're just going to, again, apply some pressure over the patella and just ask the patient to extend their leg out like this. And again, you're still looking for a reproduction of the patient's pain or any signs of crepitus as the patient extends their leg out and you apply pressure onto the patella. So one test we can do if we are suspecting patellofemoral dysfunction would be the McConnell test, and this test is performed with the patient seated off the bed and applying resistance in multiple degrees of flexion. So as we are performing this, we're going to be performing this in 120 degrees of flexion, 90, 60, 30, and full extension. So what you're going to do is you're going to start with the patient in 120 degrees of knee flexion, and just going to want them to resist me. So they're basically just going to contract their quads. So I'm going to place my hand here, and we're just going to ask the patient to try to push into my hand so she's resisting me. And if the patient does not feel their pain here, then you're going to move on. So now you're doing 90 degrees of flexion. Same thing, ask the patient to resist you. If she still feels no pain, then you can move to 60 degrees, and you do the same thing, contract. And then you would move to 30 degrees of flexion and contract, and then full extension and apply some resistance. Now, if at any point the patient had their pain during that test, you would complete the entire test, going from 120 degrees of flexion to full knee extension, and then you want to go back to the point where the patient said they experienced their pain. So if Jasmine experienced her pain at 90 degrees of knee flexion, now what you're going to want to do is the same thing, but you're going to try to push the patella more medially. So as you are pushing the patella medially, you're going to ask them to again resist you. And if as you do this it is less painful, that would be a positive McConnell's test. So positive test is if you go through the whole test, you go back to the motion where it was painful, apply that medial pressure onto the patella, and it is less painful. So if you are suspecting that the patient is having lateral knee pain, and let's say they have a positive Ober's test and maybe you're suspecting some IT band friction, you can do the Noble compression test. So you're going to place the patient in this position of flexion, and you're going to use your thumb in the web space of your hand to kind of find the lateral femoral condyles and come just off of that and apply some compression in this area. So now what you want to do, applying your compression here, you're going to want to extend the knee. So as you apply your compression and extend the knee, if you get to about 30 degrees and the patient complains, oh, that's my pain, then that could be a positive test because you're placing stress on the IT band. So that could indicate that there is some IT band friction or irritation here. So again, a positive test would be that as you extend the knee, if you get to about 30 degrees, that's when the patient feels their pain, that reproduces their pain or symptoms. That would be a positive test.